Yeah, good evening, everybody. It's my pleasure today for the last day of the Wave 2. Yesterday, we have a fruitful discussion with the international speaker and national speakers about hypertension in a special population. And today, we have two sessions and we have a closing remarks. It's an honor for me to have with me in these sessions, which is about hypertension in special population, Professor Shama Bulain, Professor Cardiology Banha University, and Professor Dr. Yasser Hussain, Professor Cardiology Ain Shams University. We have three important topics today, and after each topic we have a discussion for 5 to 10 minutes. Dr. Hisham.
Good morning, good afternoon. It's a pleasure for me to be with you today. And actually, this meeting came true finally after two major problems. One was a tornado we had, and then COVID. So thank you, Dr. Sobhi, for making this event come true. And of course, it is nice to share my dear colleague, Dr. Yasser Hussain and Dr. Osama Sanad, this session, which is about hypertension in special populations. And we are going to start with the presentation, which is for Dr. Osama Sanad, which will be under the topic of isolated systolic hypertension. So now we are going to hear this interesting presentation from Dr. Osama.
Thanks to Professor Dr. Muhammad Sobhi and my dear friend Dr. Tariq Zawawi, Mr. Chairman, ladies and gentlemen, let me to discuss together this very important issue, the management of frail elderly hypertensive patients with isolated systolic hypertension. Let me to go back by the year of 1930, and the strategy at that time for treatment of hypertension is that hypertension may be an important compensatory mechanism which should not be tampered with, even we're certain that we could control it. Later on, and after 15 years, at the age of 1946, the strategy at that time was that people with mild benign hypertension with a level up to 210 over 110 need not be treated. And there is a psychopathologic personality associated with hypertension. So now, ladies and gentlemen, let me to ask, did this strategy in the management of hypertensive patients do well? In the following few minutes, I will discuss with you the positive and negative point of treatment in hypertensive patients in a special frail group above the age of 70 and 75. By the year of 2008, high trial hypertension in very elderly, including about 4,000 patients above the age of 80 with a systolic blood pressure above 160, were randomized into two groups. First was active treatment in indapamide, and second with placebo group, and were followed up for 2 years. At that time, the result was a significant reduction in any fatal or non-fatal heart failure, any fatal or non-fatal cardiovascular event in a group of active treatment with indapamide versus placebo group without treatment. And a significant reduction in fatal and non-fatal stroke, death from stroke, death from any cause in group of indapamide treated group versus placebo group. And the systolic Euro trial reported a 50% reduction in the risk of dementia in treatment group. Again, progress with Brendobril found a protective effect for the cognitive function in the treated group versus placebo group. This finding did not found in SCOPE, CHEAP, and Harvard cognitive trials. However, in a meta-analysis of hypertensive treatment trial in people above the age of 80, there were a significant reduction in the stroke, significant reduction in the incidence of congestive heart failure, and reduction in coronary artery disease, but not significant, with a little increase in mortality, which is not good. This is a very interesting trial national trial in Portland, and about 5,000 people above the age of 70 were classified into 3 subgroups. First group received no antihypertensive medication. Second group were in a moderate intensity antihypertensive medication. And third group were high intensity antihypertensive medication followed up for 3 years for a serious full injury, including hip or other major fracture, traumatic brain injury, and joint dislocation. And they found that there was no significant difference between the 3 subgroups, between the group of no medical therapy and between group of moderate intensity and high intensity. There is no significant difference as regards serious full injury, which is a good. Again, no significant difference as regards the number of antihypertensive classes used in the 3 groups with relation to the serious full injury. And no class of antihypertensive medication was associated with an increased risk of serious full injury. All were the same. And the most important significant predictor for serious full injury in hypertensive patient treated with antihypertensive medication, whatever the type, was past history of transient ischemic attack or past history of full injury before in the past 1 to 2 years. However, the mortality was higher in patients reporting serious full injury compared to those who didn't report this finding. So now, questions. How far should systolic blood pressure be lowered in elderly? Let us look to the old study. Hot trials, cheap trials, and systolic cure trials, they ended with a systolic blood pressure from 140 to 150. That to say, no evidence at that time to support lowering systolic blood pressure below 140, but below 150, and the systolic blood pressure below not more than 60 millimeter mercury. Let's discuss together SPRINT trial, which changed the strategy of treatment of hypertension in population, especially elderly population. They were classified to arm standard therapy with a systolic blood pressure 136 and intensive medical therapy with systolic blood pressure 120, and they are followed up for 3 years. There is significant reduction in intensive group as regards the primary outcome, as regards all cause of heart failure and cardiovascular mortality compared to standard therapy with systolic blood pressure 136. Again, as regards serious adverse effects, a significant increase in the incidence of hypotension, in the incidence of syncope, the incidence of electrolyte abnormality, acute kidney injury, or acute renal failure in group of intensive medical therapy. When we subgroup as regard group of below the age of 75 and above the age of 75, there is no significant difference as regards the beneficial or the hazard in these 2 subgroups. This means that the intensive treatment is as useful as an elderly patient above the age of 75 as those below the age of 75. In conclusion, for this SPRINT study, serious adverse event associated with hypotension, syncope, electrolyte abnormality, and acute kidney injury or acute renal failure are more common in intensive group when compared to standard therapy. However, overall, the benefit of more intensive blood pressure lowering exceeded the potential for harm. Let us ask, what is the mechanism in elderly population? And what about central aortic pressure and brachial pressure? Central aortic pressure vary throughout the arterial tree, such as aortic central systolic pressure is actually lower than corresponding brachial value. Second, the difference is highly variable between individuals. Third, central aortic pressure is better related to future cardiovascular event than is brachial pressure. Antihypertensive drug, which is important, can exert a different effect on brachial and central aortic pressure. That means some drugs that act on brachial pressure, lowering the blood pressure, and in central can do that, like beta blockers. The central aortic pressure is higher in gender male when compared to gender female in all age groups starting from 20 years up to 80 years, which explain the increased incidence of cardiovascular event or complication related to hypertension in male gender compared to female gender. And when a large conduit artery are healthy and compliant, like in young subjects, the reflected wave merge with the incident wave in the proximal aorta, mostly during diastole in young populations, thereby augmenting aortic diastolic pressure and supporting coronary perfusion and preserve the pulse pressure without increasing systolic pressure. However, in elderly subjects with artery stiff, with wave travel, pulse wave velocity higher, is faster than the young population, and the reflected wave merge early with the incident wave, augmenting the aorta systolic and decreasing the diastolic rather than diastolic pressure, which lead to isolated systolic hypertension. Like this figure, this is a systolic hypertension, diastolic hypertension in elderly compared with young population, systolic and diastolic, high systolic blood pressure, wide pulse pressure in elderly population due to stiff aorta and faster pulse wave velocity. As regard medical treatment, the nitrate have the more powerful reduction in central aortic pressure compared to any other group, followed by ACE inhibitors and angiotensin receptor blocker, compared to beta blocker, which increase the central aortic pressure compared to the brachial pressure. Hence, the complication is higher with beta blocker and lower with nitrates, calcium channel blockers, and angiotensin receptor blockers, which was proved previously in Life, ASCO trial, and Merck trial, which compared the different drug treatment and complication in elderly that was related to central aortic pressure more than brachial pressure. Many studies reported some value of vitamin D in aortic stiffness, blood pressure, cardiac function, especially elderly population. However, this study, in the recent study, and more powerful and important, reported that there is an absence of any significant effect of vitamin D supplementation in any dose, moderate or high dose, on the blood pressure level and aortic stiffness and on cardiac function, suggesting that any beneficial effect of vitamin D on cardiovascular disease are unlikely to be mediated through this mechanism or through vitamin D. Let us to discuss and found what the guideline previously said, 2013 versus 2018. The yellow color means class 2B, green color means class 1. Antihypertensive drug treatment may be considered in elderly population between the age of 65 up to the age of 80, when systolic blood pressure is from 140 to 160, provided that antihypertensive treatment is well tolerated, which is very important, provided that the patient can tolerate the antihypertensive treatment. Recently, the same statement, but changed from class 2B to class 1. Second, the target blood pressure, systolic blood pressure in elderly population, aged from 65 to 80, from 140 to 160, 130, 140, so the target is reduced. Now, both class 1, but there is a decrease in target blood pressure about 10 millimeter mercury. And third, initiation of antihypertensive therapy with two drug combination may be considered early in patients with systolic blood pressure. However, recently, it is class 1 two-drug combination, preferred single pill combination. However, an exception to start with two-drug combination, single pill combination, is that in frail elderly patient, it is allowed to start with one drug, especially in those patients with at low risk or even grade 1 hypertension, particularly if the systolic blood pressure is lower than 150. Finally, elderly population is increasing, definite, and the dilemma in treatment is aggravated by the changes in their physiology and arterial structure brought about by aging. Every elderly hypertensive patient might react differentially to the treatment. And thank you.
To Hisham, I was curious, and discuss together like take home message of for this topic. We have a definition of frail والالدري وايزوليت systolic hypertension. فالالدري يعني الاول to begin with هو الالدري is more than 80 ولا الالدري from 65 to 80؟ والديفينيشن انتوا شايفين ايه الديفينيشن بتاع الالدري؟ دكتور ياسر.
هو الحقيقه انا اعتقد دكتور صبحي ان they are not one category. elderly patients الحقيقه we can classify يمكن في الجيرياتريك medicine they classify into young, old, and old, or the octogenarians. So we may have some sort of aggressive regression, a little bit aggressive regression in those 65 years old or 70 years, but I cannot go for further blood pressure reduction in isolated systolic hypertension in those who are octogenarians, especially because the pulse pressure is huge and the diastolic blood pressure would go further and further low, and this may let the patient enter into cardiovascular episode, coronary vascular disease, cerebrovascular insufficiency, etc.
بس هم هنا في الجايد لاينز دكتور هشام برضه معانا، هم في الجايد لاين عاملين 65 to 80 ومور ذان 80 عشان نفرق كده، عشان كده اولد والالدري. فهو بعد احنا في ديفينيشن تاني او ترمينولوجي اسمه فريل، عشان كده الفريل ده اونلي انديكيشن انك تديله سنجل بيل، سنجل دراج. المونوثيرابي بيبقى موجود في الفريل الدري بس، لكن دايما كومباين دلوقتي ذا تريتمنت في كل الهايبرتنشن. فاحنا عندنا فريل والدري، والجايد لاينز هنا بتقول في الجايد لاينز اللي هو كان الدكتور اسامه جايبها كاتب ان انت تدي كومباينيشن ثيرابي. ف وات دو يو ثينك؟
هو بس خليني بس انترفير قبل ما نخش في النقطه دي دكتور محمد. هو what Osama mentioned about the pulse wave velocity and its reflection and its impact on the systolic blood pressure. So what we are measuring peripherally, is it really the diastolic blood pressure or the underestimation of the true diastolic blood pressure?
لا هو هنا دلوقتي بنتكلم على لو هو diastolic blood pressure وفريل ده مونوثيرابي. بس هنا
انا اقصده بس لانه what Dr. Yasser was raising is that when we treat the systolic blood pressure, then we are reducing the diastolic blood pressure as well. And according to what Osama was mentioning, that this is the peripheral blood pressure is not really indicating that what's happening centrally exactly because of the pulse wave velocity and the rigidity of the blood vessel. Of course, we know it is lower in all the patients, but is it really that low, or we are overestimating it? It's the degree it is lower too.
طب هو ده comes to the question، هل انت it's wise to make the central blood pressure in such kind of patients؟ يعني to measure it؟ يعني دول indication low؟ ايه رايك ياسر؟ ايه رايك؟
I think systolic blood pressure also is overestimated because of the atherosclerosis and because of the amplification of the pulse pressure at the peripheral arterial disease. So, as Professor Hisham said, not only the diastolic but also the systolic is overestimated. So we cannot go for, to my judge or to my opinion, I cannot go easily for combined therapy for a hypertensive elderly patient. I would go with those and to taper up the dosage forms or the combination therapy.
هنا في questions coming من الاودينس. if blood pressure 200/60 and if drugs decrease both systolic and diastolic blood pressure. يعني انت لو واحد عنده 260 والدراجز دي انت اللي هو دراجز المفروض ان انت بتدي يا ايس يا اي ار بيز يا كالسيوم شانل بلوكرز وكونترا انديكيشن دايريتكس اور بيتا بلوكرز on these patients. او والكويشنبل اباوت نايتريتس احنا we don't give nitrates في التريتمنت بس هي بتقلل. لكن هنا لو 260 ايه التريتمنت اوف تشويس؟ شايفين ايه؟
over what دكتور صبحي they say؟
Yeah, 200/60.
over 60 yeah 200.
60 يعني لو دايستوليك بريشر. فلو دراجز مثلا كالسيوم شانل بلوكر هل هي بتقلل السيستوليك والدايستوليك ولا بتعمل اب تايتريشن تو ذيس بيشنتس؟ I think ان هو الانسر اوف ذيس ان انت you have to start a small dose with up titrate لغايه ما توصل لل 140 في لو نزل الدايستوليك عن 65. اهم حاجه البيشنت ما يكونش عنده كروني ارتي ديزيز عشان الجي كيرف زي ما كنا بنتكلم امبارح على موضوع كروني. otherwise يعني this patient is purely isolated hypertension is not diastolic hypertension. فهو ده الايم بتاعنا ان احنا نقلله بالراحه عشان ده متهيألي المسج. اعتقد السلايدز بتاع الدكتور اسامه كانت واضحه قوي في الاخر في الجايد لاينز ان احنا ترانزيت كلاس 1 ايه. انتوا رايكم ايه في التشينج اوف ذا جايد لاينز دي؟ هل سبرينت افكت ولا في حاجه ترايلز ثانيه ولا ايه؟ دكتور ياسر.
First, the patient with the 200/60, we should not forget to go for the non-pharmacologic treatment and for the lifestyle modification because these patients suffering from some sort of Alzheimer and they may take a lot of salt intake and they may go for coffee consumpmption. So non-pharmacologic aspect should not be forgotten in these kind of patients.
دكتور هشام تحب كومنت على القصه دي؟
Actually, again, in these patients, as you have just mentioned, I would like to lower the systolic blood pressure to the degree that can be tolerated by the patients and make sure that he is not symptomatic with blood pressure lowering. And again, make sure that we are not reducing the diastolic blood pressure less than 60 and making sure that this has no burden on his coronary blood flow. But still, I would go for his symptomatology whenever I lower the blood pressure. When it is not tolerated anymore by the patient, probably I should stop at this level and should not go lower down.
يعني احنا بالتيك هوم مسج من البرزنتيشن اوف دكتور اسامه سند. اولا الميكانيزم is evident. Number 2, take care of the central aortic pressure. 3, they have 2 tables, 1 table for the guideline and 1 table for the drugs. I think this finally it's an excellent presentation. Now I'm going to introduce Dr. Yasser Hussain. Dr. Hussain is going to speak on the reverse, the young, isolated systolic hypertension in the young. So this, I think this is very interesting to see the change between the frail elderly and the young. Dr. Yasser?
Thank you, Professor Sobhi, for this kind invitation, and thanks goes also to CVREP and the ESH conference for inviting me for this mysterious subject. We'll talk today about the isolated systolic hypertension in young. Let me go for my pre-agenda, and I insisted to put this item, the pre-agenda. My role today is not only giving a typical academic overview, but trying to pay your attention to some points. The underestimation of the problem is so evident. We are all underestimating having a young subject with hypertension because of ignorance of the patient himself, the family, and the reluctance of the doctors that this patient in this age would have no hypertension. And this raises also the importance of suspicion, the clinical suspicion of a patient or for a subject that because we all know that hypertension is a silent disease. So clinical suspicion is a crucial tool to diagnose these patients, especially if they are overweight, smokers, having strong family history, etc. Do not forget that essential hypertension is the main in the country of the general belief that young subjects are suffering from secondary hypertension, but the majority, as I will show you, are for essential hypertension. And do not forget the proper diagnosis criteria from measuring the blood pressure when the patient is sitting, his back to the chair, his arm is put on the table, etc., the cuff size, and all these measures. So, dear all, welcome to the land of heterogeneity and uncertainty. When I went through the literature, there was a lot of heterogeneity in the trials and the studies, and uncertainty also. My agenda: definition of the young, definition of isolated systolic hypertension, isolated systolic hypertension magnitude of the problem, ESH fundamentals, treatment with its question mark and exclamation mark, and take-home concepts. What is the definition of young? Let's put the definition of who, and a lot of claim today comes for who, and its way of act. Here, let's go to our subject. Young definition. The World Health Organization defines adolescent as person between 10 and 19. And this range falls within the WHO definition of the young people, which refers to age between 10 and 24. Not the whole. United Nations defined youth as 15 to 24, and in some cases to 30 or 40 years old. The Society of Adolescent Health and the range from 18 to 25. And as you kindly see, the lack of a constant definition of young age for people with isolated systolic hypertension in young has contributed to the variations in judgment. What about the definition of isolated systolic hypertension? We are lacking a pure definition for those who are young. We have the isolated systolic hypertension definition as systolic blood pressure equal to or more than 140 millimeter mercury and diastolic blood pressure below 90. What is the magnitude of the problem? I think Sir William Osler a century ago made a marvelous quotation about the vascularity. He said that the tragedies of life are largely arterial, but longevity is a vascular question. And this was quite good by the time to say so. The main problem that guidelines are based mainly on randomized trials almost exclusively among older, higher risk patients, whereas younger, standard, or low risk young adults are not well presented in the knowledge database we do have. Most, if not all, the information of hypertension in young adults stems from observational studies with all its question marks. I insisted to put this slide from the last European guidelines for management of hypertension, addressing the incidence and typical cause of secondary prevention. Of course, the young children or the infants, we have here a huge percentage of having secondary hypertension, but if you see, only 10 to 15% secondary causes of hypertension, young adults, and even middle-aged 5 to 15. So essential or primary or idiopathic hypertension is the main leading. Also, the prevalence of isolated systolic hypertension in adolescent and young to middle age, you can figure out here the prevalence is not the same, ranging from only 2% to 5.9%, reaching in some studies 48% in males mainly, severe disease, 28%. So prevalence is varying according to the population and to the type of the study. Does this study is this study cross-sectional one or longitudinal study? This would behave in changes in the prevalence of the isolated systolic hypertension in young. Another big problem that isolated systolic hypertension, if you compare it with the isolated diastolic and the combined systolic diastolic, you can figure out here that the least in probability of receiving an initial hypertension diagnosis is for those who are having isolated systolic hypertension. Not only if we analyze the types of hypertension ranging from optimal normal to high normal, isolated systolic, isolated diastolic, and both systolic diastolic elevations, you can figure out here the purple line for men having a good share in cumulative incidence rate of cardiovascular disease mortality, and also for those in, those for the women being the second cause, but here the curves are blunted a little bit because hypertension is a male gender disease mostly. Authors who are interested in this subject are dealing with two opposing theories: the innocent condition view and the true hypertension view. And we have three critical questions. I think they are all in your minds now. Is this condition hazardous? Does it translate into frank hypertension later on in life? Does it necessitate treatment? I think they are the main three critical questions that we may have some answers on them. It is one of the most important studies concerning isolated systolic hypertension in young and middle-aged adults because it had 31-year follow-up to show the risk of cardiovascular mortality. And it was addressed by Yano et al., one of the legends in this field. And they concluded that over long follow-up, 31 years, younger and middle-aged adults with isolated systolic hypertension and higher relative risk had higher relative risk of cardiovascular disease and coronary heart disease mortality than those with optimal normal blood pressure. Another legend which is Professor Rook took the other side, said with his colleagues that subjects sometimes have normal central blood pressure, and stress upon the word sometimes have normal central blood pressure, and no evidence is available that they benefit from antihypertensive treatment. On the contrary, there are prospective data that the condition does not necessarily, and stress upon the word necessarily, proceed to systolic diastolic hypertension. So he is on the side of the innocent view theory. Another one of the eminence in this field, Professor McHenry and his colleagues, said that isolated systolic hypertension in young people is associated with increased future risk and requires careful evaluation, and the term spurious, zaif, and pseudo hypertension are unjustified. So, after all of this, what are the main isolated systolic hypertension fundamentals? This caricature explaining the increasing prevalence of hypertension in young, and I think it applies also to our COVID era, because he's talking about junk food. We are doing now so TV and the computer. So I ask God not to come up with hypertension at the end of the COVID catastrophe. So the change of the globalization that made to the population, younger patients who are not on good lifestyle may experience hypertension. Hypertension, isolated hypertension in young is also the most common form of hypertension in adolescent and young adults. Again, on contrary of the general belief, isolated systolic hypertension in young adults is increasing in prevalence, particularly in men. The causes are coming now in the coming few slides. Large artery stiffening is not thought to be the underlying condition, of course, in younger individuals, although the precise mechanisms and longer-term risks associated with it in young people are still debatable. Again, numerous studies in young patients with borderline hypertension have demonstrated that cardiac output and heart rate are elevated, and this isolated systolic hypertension is the predominant phenotype. Elevated cardiac output is neurogenic, running short of time. The ENIGMA study showed us that premature aortic stiffening. ENIGMA study investigators concluded that same pathophysiologic mechanisms underlying as older patients, and they concluded that systolic blood pressure and cardiac output in normal weight individuals having the stronger correlation, or the stronger correlation or association between systolic blood pressure and peripheral vascular resistance in overweight patients. This is not important because we are running short of time. Marked sympathetic nervous system activation is there. Obesity, lean, tall patients, increased salt intake, lack of physical activity are involved, obesity and metabolic disturbances also. And here is the schematic. I would like to have only 1.5 minutes more. Schematic representation here for tracking peripheral systolic blood pressure, central blood pressure, and peripheral diastolic blood pressure across all age subgroups. And here you can figure out this blunt effect, the blunt curve here as regard the peripheral systolic blood pressure in those from age of 40 and up. And here you can figure out that from 14 years old to 28, you have elevated systolic blood pressure, mostly because of high stroke volume, high heart rate, and high cardiac output. Excess body weight can interact into, translate into insulin resistance, salt intake, and inflammatory mediators, and this would increase or elevate the arterial stiffness with isolated systolic hypertension. Our treatment, authors dealing with innocent and the true theories, but the most important one coming from the Helios study, where the authors concluded that discriminating high from low cardiovascular risk is the main issue. This would have treatment and this would not have treatment, and this is based on the central aortic blood pressure. This is an algorithm. This is the last slide before take-home message about how to deal with these patients. You should go for out of office measurement, ambulatory or home. If the patient is good, just search for target organ damage. Low risk, go for lifestyle. High risk, consider pharmacology. If the ambulatory and the home blood pressure showed that the blood pressure, systolic blood pressure, is elevated, measure the central blood pressure. If high central blood pressure, consider treatment. If low central blood pressure with no cardiac or with no target organ damage, lifestyle. If low central blood pressure but high risk profile go for treatment. Treatment, non-pharmacologic, loss of weight, salt restriction, exercise, conventional drug therapy, and the most of data goes for RAS blockade, and some data goes for only propranolol and nebivolol in beta blocker if were used. Take-home message in one slide. Isolated systolic hypertension in young is still a debatable issue, classified as benign state in some authors' opinion and hazardous subject in other opinion. Etiology is also mysterious, with a lot of things to explain, not as thought before. It is not uncommon. Treatment is non-pharmacologic policy at the start, then with drugs in some cases, and at last, only future clinical trials will elucidate if a benefit can be achieved from pharmacologic treatment or not. Thank you.
Thank you, Dr. Yasser. I think you have a difficult task, and you look for the literature. You don't find still now the exact mechanism of isolated systolic hypertension, which is I think there's a question of the 2 or 3 of the audience. What is the exact mechanism of isolated systolic hypertension? The young, the best treatment. It is evident in your take-home message. So can you give us in practice when I'm age, for example, I'm 30 years old, coming to 25 or 28, coming to you with hypertension, how frequent you measure the blood pressure, how you measure the blood pressure, what are the investigations you need for this patient, and then how the treatment?
Okay, if I had a patient with 30 years old and coming to me with elevated systolic blood pressure, I should apply the rules of measurement of blood pressure that a lot of physicians ignore. It may take a lecture to judge or to explain it, but I would go for the remeasuring the patient 2 to 3 times within the visit, because a lot of these patients are experiencing white coat hypertension, and this is written in literature. So try to measure the blood pressure, of course, on both sides. Then, after taking the history and discussing some instructions with the patient, evaluate your blood pressure and try to measure it in another session, because we do not diagnose hypertension from one reading in one session. Of course, I would like to go thoroughly within the history of the patient. Does he salt consumer? Does he play regular sports? Because athletes have high cardiac output, and they are not classified as hypertensive patients unless we go for invasive or even non-invasive with tonometry, the central aortic pressure, and find that it is elevated. If it's not elevated, the brachial blood pressure does not signify having hypertension, because at any point of the circulation, the incident wave, the outgoing wave, and the coming wave shows sometimes some sort of amplification. And we found in literature that tall, lean persons would have this subject, because the signal travels along the way to the periphery, and the coincidence comes from the outgoing and the recurrent wave.
Hisham? Any questions, Dr. Hisham?
Thank you very much. It was very clear message from Dr. Yasser. And actually, we were met with these young individuals frequently. And I think the issue of considering the ambulatory blood pressure, I usually do this actually for young patients that come in complaining of systolic hypertension. In many cases, when we do ambulatory blood pressure measurement, usually it is okay, they don't have a problem. Otherwise, I think in those still in the gray zone, considering the central blood pressure measurement would again be an issue that we should consider in those patients in the coming days or years. Thank you very much.
May I introduce my dear professor, Professor Dr. Hisham Abulainin, Professor of Cardiology, Banha University, and the former Vice President of the Banha University. I think he will talk about a very interesting subject, the diagnosis and the treatment of blood pressure in women, because we all know that they are not addressed enough in most of the clinical trials. So I'm happy also with the term blood pressure, not hypertension in women. I appreciate a lot. So, Professor Hisham.
Okay, thank you very much. Good afternoon, everybody. And I would like again to thank Dr. Sobhi for bringing this event to life and actually giving me an important topic in the era of female predominance. Now we are the most important, actually, we are complaining of being undertreated as men. So it was a difficult, not a difficult task, but important task is to see the gender difference regarding females and how should we diagnose and manage hypertension in those females. Another important part of my task was to make that everything is going okay and make sure that my pants are matching my suit to not to miss anything in this important presentation like this guy here. So a gender-specific approach to cardiovascular disease has been practiced for decades, although not always to the advantage of women. And despite the lower absolute risk of cardiovascular events in women compared with age-matched men, the majority of women die from cardiovascular diseases. Most cardiovascular events occur in women with non-traditional cardiovascular risk factors. So, improving risk factors management in women of all ages therefore yields an enormous potential to reduce cardiovascular morbidity and mortality. Aside from smoking cessation, which actually became a big problem in females these days, hypertension control was found to be the single most important intervention to reduce the risk of future cardiovascular events in women. And so I'm going to focus on the peculiarities of hypertension as they pertain to women and points out where diagnosis and management of hypertension may require a gender-specific concerns. So as we all know that hypertension is a significant and very important cardiovascular risk factors for both stroke and coronary heart disease. Regarding stroke, age-specific association of stroke mortality with blood pressure appear to be slightly less extreme for women than for men. However, the age-specific associations of coronary heart disease mortality with blood pressures are more profound in women than in men, albeit not significantly. In the Chicago Heart Association study cohort, high blood pressure was the most common major risk factor in women and independently increased the risk of coronary heart disease mortality with a relative risk 3.17, which was significant. And as compared with optimal blood pressure, high normal blood pressure was associated with risk factor adjusted hazard ratio for cardiovascular diseases of 2.5 among women as compared to 1.6 among men. And therefore, reduction in the prevalence of hypertension have the potential to dramatically reduce the burden of coronary heart disease in women. What about sex differences in blood pressure? So blood pressure tends to be marginally lower in women than men regardless of age, even though 70% of women with hypertension are aware of their diagnosis, less than 1/3 achieve adequate blood pressure control, so they are actually undertreated. Blood pressure differences between the sexes remain largely speculative. Some data imply that menopause contributes to the development of hypertension in women. In some trials, an animal trial, gonadectomy resulted in an accelerated development of salt-sensitive hypertension in female animals, indicating impact of sex hormones on renal salt handling. And while the blood pressure response of premenopausal normotensive women is insensitive to dietary salt intake, blood pressure in postmenopausal women becomes salt sensitive. So this may be an explanation for the good response to dietary interventions such as sodium restriction in this patient group. Menopausal women have higher blood pressure values and worse risk profile than premenopausal women, which is related to their older age rather than altered hormonal state. This figure actually shows us that the problem of salt sensitivity is a combined problem in females. So estrogen cessation results in two pathways, one which affects the kidney directly, leading to salt sensitivity, and the other one is through centrally, affecting the sympathetic overdrive, and this in turn again results in salt sensitivity. That is why they claim that both diuretics and beta blockers would be important treatment modalities in postmenopausal females. In this figure, as we see, the degree of hypertension control and prevalence rates in USA in the upper panel, these are the control rates, and as we see, especially in younger age groups, between 20 to 44, there is less than 50% control of blood pressure in female as compared to almost 70% rate of control in the counterpart males. And then this difference above 45 to more than 75 is reduced to a great extent with more or less equal degrees of blood pressure control in both males and females. In the lower panels, the prevalence rates of hypertension, and as Dr. Yasser was mentioning, there is high blood pressure in younger patients, which is essential hypertension. So in the age group 20 to 34, we have a range in female which is a little bit below 5% as compared to 10% in males. Then this increases a little bit between 35 to 44 to about 20%, which is a little bit again less in male. Then again, the difference is reduced between males and females as at the age of menopause to be almost around 50 to up to 75% in the age group more than 75. So now what about issues which are specific to women? The first one is pregnancy and pregnancy complications. So pregnancy-associated hypertension affects about 10% of all pregnancies and greatly increases the risk of maternal and fetal mortality. And hypertension during pregnancy can be divided into the following groups: chronic hypertension, gestational hypertension, preeclampsia and eclampsia, and preeclampsia, eclampsia superimposed on chronic hypertension. So we have four groups of hypertension during pregnancy. Women with pre-existing hypertension are more likely to have complications during pregnancy than those with normal blood pressure. Finally, another important aspect about preeclampsia is that it is an emerging risk factor for future cardiovascular events. The second issue is hormone replacement therapy. And there are conflicting data regarding the impact of hormone replacement therapy on blood pressure in menopausal women. In a trial where they evaluated the effect of estrogen or estrogen-progestin regimens on cardiovascular risk factors in postmenopausal women and found no detectable effect on blood pressure. Also, in the Women's Health Initiative, women on hormone replacement therapy had a higher prevalence of hypertension than did women on placebo after adjustment for cardiovascular risk factors. And there was a slight but significant increase from baseline in systolic blood pressure among women randomized to conjugated equine estrogen and medroxyprogesterone acetate compared with a placebo group. Overall, changes in blood pressure owing to hormone replacement therapy are likely to be modest and should not preclude its use in normotensive or hypertensive postmenopausal women if menopausal symptoms are severe. Finally, in this regard, it is generally recommended that hormone replacement therapy should be used to the lowest effective dose for the shortest possible duration. Finally, in these specific issues to female are the oral contraceptive pills and can be a cause of hypertension in younger women with high blood pressure, 2 to 3 times more common in women taking oral contraceptives. So they have the potential to triple the incidence of hypertension in young females. In the Nurses' Health study of more than 60,000 women showed that the adjusted relative risk of development of hypertension was 1.8 for current user of oral contraceptives compared with women who never used them. And that the absolute risk, however, is extremely low in the general population, with only almost 42 cases per 10,000 persons years attributed to oral contraceptive use. Blood pressure response to combined oral contraceptives appear highly variable, and only a small minority of women may experience the onset of frank hypertension. In the Royal College of General Practitioners, oral contraception study current use of oral contraceptives increased the risk of subsequent myocardial infarction only in women who also smoked. So the combination of oral contraception with smoking has a deleterious effect on females regarding cardiovascular diseases. Now, what about treatment of hypertension in women? According to the guidelines, of course, lifestyle modification is an integral part of blood pressure management and may even be sufficient in selected mild cases. In the INTERSALT study, which is a very important trial, investigated systematically the relationship between urinary sodium excretion and blood pressure in over 10,000 people, half of whom are women. The results suggested that lower average sodium intake reduced the blood pressure. In a reanalysis of that trial, it concluded that reducing sodium intake by about 6 grams per day could lower systolic blood pressure by 3 to 6 millimeters of mercury. And population studies indicate that such improvement in average systolic pressure levels could substantially reduce the rates of major cardiovascular events and mortality. And actually, some countries like Finland actually succeeded to reduce salt intake and had very good results concerning nationwide reduction of blood pressure. A Cochrane review, however, could not show that simply advising patients to reduce sodium intake was associated with fewer cardiovascular events, even though an beneficial effect on blood pressure was observed. In addition to weight reduction, physical activity, dietary sodium reduction, and moderation of alcohol consumption, GNC8 endorsed DASH diet for patients with elevated blood pressure. Regarding pharmacotherapy, blood pressure lowering treatment trials collaboration provides convincing evidence that women respond to antihypertensive drugs similar to men. And gender continues to have an important role in individual risk assessment, but needs not otherwise influence decisions about the need for antihypertensive therapy, the intensity of blood pressure reduction, or the choice of drug class. Also, special consideration may dictate treatment choices for women. For example, first-line treatment for a woman who developed hypertension while taking oral contraceptives is stopping the oral contraceptives and switching to a different form of birth control. Also, ACE inhibitors and ARBs are contraindicated for women who are or planning to become pregnant because of the known risk of fetal developmental abnormalities, and that the threshold to initiate blood pressure lowering treatment during pregnancy are 160 systolic over 110 diastolic, and below these thresholds, treatment must be individualized because current evidence does not support more aggressive medical intervention. Alpha-methyl dopa and dihydropyridine calcium channel blockers are among the recommended antihypertensives in this setting. Thiazide diuretics are particularly useful in elderly women because their use was associated with decreased risk of hip fracture, which is common in females postmenopausal, probably by reduction of urinary calcium loss. And in addition, thiazides appear effective in reducing the risk of stroke in elderly women, another advantage. And finally, biochemical responses to drugs may be gender dependent, with women more likely to develop hyponatremia or hypokalemia, and men more likely to develop gout in response to diuretic therapy, and I can tell you about that myself. In this figure, as we see that American Heart Association guidelines for cardiovascular disease prevention in women 2011, they stated that thiazide diuretics should be a part of antihypertensive drug regimen unless contraindicated, and that recommends reporting of gender-specific analysis of both efficacy and adverse effects of preventive intervention. ACE inhibitors induced cough 2 to 3 times as common in women as in men, and then ARBs become a good alternative. And furthermore, women are more likely to suffer from calcium channel blocker-related peripheral edema and minoxidil-induced hirsutism. Centrally acting agents and beta blockers and thiazide diuretics may sometimes be associated with sexual dysfunction in women as well as in men. Combination therapy with multiple antihypertensives, as we do these days at maximal doses, may be more effective in blood pressure control while reducing the incidence of side effects linked to higher dose of single drugs. Now I will come to my take-home messages. Mr. Chairman and my dear colleagues, hypertension is underdiagnosed and undertreated in women. Elevated blood pressure has a stronger impact on coronary heart disease mortality in women than in men. The rate of cardiovascular events in women is very low when blood pressure is optimal. Reduction of hypertension prevalence in women have the potential to dramatically reduce coronary heart disease burden in women. Although 70% of women are aware of their hypertension, less than 1/3 achieve adequate blood pressure control. The proportion of cardiovascular events preventable by blood pressure control is 30 to 100% higher in women than men. Issues specific to women, as we have mentioned shortly, hypertensive disorders of pregnancy, hormone replacement therapy, and oral contraceptives. Women and men have comparable benefits of hypertension treatment. And finally, women respond to antihypertensive drugs similarly to men. Finally, if I have to say thank you, I would say it for those frontiers who fight a very serious pandemic, which is coronavirus, and they are putting their lives at risk in order to help people suffering this dreadful disease. Please let me applause for them, and please share me for this. Thank you very much.
Thank you, Shem. It's a wonderful talk. I think something is new for me, that's about the side effects, which are similar, different from male and females. You said that cough is more, edema is more.
Sounds more than is.
Yeah, which is strange enough, but it's we have to take into the so the importance, the prevalence, the stay on therapy differs between male and female about the control, and regarding the hormonal change, and finally this difference in. So when a young female come to you, for example, after exclusion of secondary hypertension, what's the drug of choice? The first drug you said that is some more. You think ARBs is better than or beta blocker, or what do you think?
Actually, what I do if I find a young female with excessive tachycardia, then I would consider beta blockers as my first choice. Actually, you know, those young females with excessive sympathetic overdrives, other than those postmenopausal, even in males, I would still consider beta blockers as one important choice. Otherwise, still we can consider, of course, ARBs in these females, and also the combination of a small dose diuretics still functions well in young females as well. So either I use a beta blocker, combination of beta blocker and thiazide diuretics based on the heart rate in these women. Then the second best option may be the use of ARB plus or plus minus a diuretic in these females. I would leave calcium channel blocker as my last choice concerning the possibility of lower limb edema or ankle edema, as I have just mentioned.
There's a question here to you and Yasser from the audience regarding the young male or female and possible renal artery stenosis or patient, how to measure the central pressure, because Yasser said central aortic pressure. So in young women, the same like young male. In Yasser, for central aortic pressure, question to you, and for Dr. Hisham about the renal artery stenosis and what the treatment of choice. Yes, sir.
About the central aortic pressure, I think it's not that applicable in clinical practice. But if we insisted to go for this for a reason or another, a tonometry or how to see the amplification of the wave would be of much importance. But I think when we come to this age group, I don't think we are in need for measuring the central aortic pressure, but to give the drugs that are proven in the literature, like in ASCA trial, the ARB and as well as plindapril and amlodipine, or the combination to lower the central blood pressure. And you all remember the sub-study, CAFE study from the ASCA trial that denoted that our calcium channel would go for lowering the central blood pressure. I think it's not that applicable clinically now and then to measure it.
Dr. Hisham, question to you regarding the women. You are hypertensive. You give the women, this woman antihypertensive. Finally, this became pregnant. How you manage these pregnant women for the drugs, the first, second, third, or we change completely?
Actually, as I have just mentioned, that safe drugs to pregnant females, including the use of calcium channel blockers, is a good option in females, as I have just mentioned. Sometimes, even if they have toxemia of pregnancy, labetalol, which is combined alpha and beta blocker, is one of the options that we can use in females. In case of toxemia of pregnancy, it is not advisable to use the diuretics because these patients are actually hypovolemic. Although they have peripheral edema, but they are a central blood, they have hypovolemia. So diuretics are definitely not indicated in females with eclampsia. So the good option here would be the use of calcium channel blocker. Alpha methyl dopa, of course, is very important drug in these cases. And finally, labetalol can be a good option in pregnant females, especially those with eclampsia.
Okay.
Professor Hisham, could I ask for Professor Hisham?
Yes, please.
You talk about the young female, okay, but imagine that you have a patient, 48 years old, menstruating, and another female, 48 years, postmenopausal. Would you go for the ARB and calcium channel blockers in this category and jump to the beta blocker diuretics because of salt restriction and the sympathetic overdrive that may happen postmenopausal? What are the philosophy within the same age but different clinical scenario, premenopausal and postmenopausal?
Actually, as I have just mentioned, that menopause is strongly linked to the issue of salt sensitivity. And actually, there is one slide as I skipped. There is a shift to the right of the blood pressure curve with increased intake of sodium in the postmenopausal women, because they, as I have clearly, they are very salt sensitive. So the issue of salt sensitivity turns dramatically after menopause as compared to premenopause. So definitely, I will change my policy. In premenopausal women, which are not salt sensitive, I have the freedom of using ACE inhibitors. I can use, of course, if they don't have the problem of cough, ARBs, calcium channel blockers, still a small dose of diuretics is okay. But definitely the choice of beta blocker and a diuretic in postmenopausal women is still a very strong and valid option for the reduction of both the salt sensitivity and sympathetic overactivity present in those females.
The question from Dr. Hani Ragi to Hisham: can we give a beta blocker with an alpha blocker like those used for benign prostate hypertrophy for pregnant women, or does it have to be only labetalol?
Actually, to my knowledge, it's the safe and the tried one is labetalol. Regarding those for prostate, I don't have data actually to endorse its usefulness, unless Dr. Hani has read something about that. But for me, what has been documented and safe for too many years is the use of labetalol.
Okay, there is a comment from Dr. Tariq Zawawi that clinical trials consider isolated systolic hypertension before the age of 50 with isolated systolic hypertension in young. In such case, central blood pressure measurement is recommended, and if it is above 120 or pulse pressure more than 50, treatment is recommended. This is to Dr. Yasser Hussain. This comment from Tariq Zawawi. Regarding another questions from Ahmed Ged regarding about hydralazine in pregnancy with hypertension to Dr. Hisham.
Yeah, hydralazine actually, I think it's not much data on hydralazine as the other drugs, but what I mentioned are probably the safest drugs that we can use in those patients. I would like just to add something because you have mentioned about the young females with renal artery stenosis.
Yes.
Actually, it's very important in those patients to treat renal artery stenosis because this is effective in young females or in young patients with renal artery stenosis. It's unlike the atherosclerotic renal artery stenosis in adults, where they found that intervention in those adults is not effective or not good for the patient. But in younger patients with renal artery stenosis, actually angioplasty in those patients is rewarding and can help in reducing blood pressure in this subset of patients.
Big question, برضه هشام, regarding female diabetic. Female diabetic, if he change in treatment, and they said in في some form of increased cough في is when more edema, peripheral edema in such patients. So لو عندك you have a female diabetic, هل الidea انك تدي ARBs with diuretic ولا it doesn't differ? ما فيش randomized trial to say this.
No, actually, I don't think there is a randomized trial for this, but as we know that in general, the use of ARBs in type 2 diabetes is protective for both the cardiovascular system and for the kidney. So actually, the choice of ARBs in those patients with type 2 diabetes is a very useful option in such patients. Regarding diuretics, I think using diuretics in a small dose if needed is okay, but of course we all know that thiazide diuretics in large doses would result in some sort of glucose, or it will make a disturbance in the glucose control in those patients. So we can go just for a small dose diuretics, maybe even up to 25 hydrochlorothiazide is okay. But higher doses would compromise the diabetes control in such patients.
Okay, thank you very much. I think we reached the conclusion. These are the three important topics today, which I think is supposed to be an easy, but it's not an easy task for all of you. It's a frail elderly for Dr. Osama, the young it's for Dr. Yasser, and the women for Dr. Hisham. I think it's more practical, and we get a great knowledge from tips and tricks to how to treat. But you should stick to the proper examination of blood pressure, the ambulatory blood pressure, the risk profile of the patients, and which drug for which patients. Thank you very much for all of you, and we have a break for 10 minutes. Keep with us, please. Thank you. Bye-bye.
Thank
you. We start the last session of the fourth day of the European Society of Hypertension Highlights, and we welcome Professor Dr. Nabil Farag and Professor Dr. Hani Raghi and Professor Dr. Sharif Zawawi for this last session with special topics. One of the interesting subject and debatable subject is the renal denervation, and there is a lot of debate, and the last guidelines of hypertension of European Society of Hypertension 2018 recommended class 3 recommendation for renal denervation till recent trials show more benefit. It's my pleasure to introduce my dear Professor Nabil Farag to introduce what is new in the renal denervation 2020. Welcome, Dr. Nabil.
Thank you very much, Dr. Tariq, and I hope all of you and all of us stay safe. We are now experienced one of the pandemic. It happens one in life. There are previous pandemics, but we didn't live these pandemics, and I hope to pass safely, inshallah, bi'idhnillah. This is my topic today about renal denervation. I will talk about what is new and what were the causes of failure of the previous trial, Simplicity 3. Actually, we have a lot of clinical trials as regard renal denervation.
with different design, different protocols, and different devices used for renal denervation. I would like to start with this meta-analysis and systematic review. The objective of this review was to determine the effect of renal denervation on blood pressure and renal function in patients with resistant hypertension in comparison to medical therapy alone. This meta-analysis found more than 600 studies, but they included only 15 studies. 15 studies included 857 patients treated with renal denervation, 616 patients treated with medical therapy alone, and only 5 studies of these 15 studies were double-blind, randomized, controlled studies with sham control. They found that the adjusted standardized mean difference in the change in office-based systolic and diastolic pressure, 24-hour systolic and diastolic pressure, and GFR from baseline to 6 months is statistically insignificant, with significant heterogeneity. But with subgroup analysis, they showed that among sham-controlled trials, اللي هي randomized controlled trials, 24 hours systolic blood pressure showed modest but statistically significant benefit favoring renal denervation in patients with resistant hypertension. And now we are talking about patients with resistant hypertension because new studies changed the concept of resistant hypertension. And this is the most of the studies done on patients with hypertension as regard renal denervation, starting with Simplicity 3 in 2014. This was a randomized controlled study in patients with resistant hypertension receiving medical treatment. These patients were receiving up to 5 drugs. And in spite of this, their blood pressure was not controlled. Moving to a blood naive, to a medication naive patients or drug naive hypertensive patients, spiral off and solo studies, 2017 and 2018. And now we have a spiral off study in 2020 that published in Lancet this year and presented in the recent American College of Cardiology. I will go through this study at the end. And back to patients who are on medical treatment for hypertension in addition to renal denervation as compared to sham procedure, but in these studies they had a specific protocols for the medical treatment of hypertension. And this was the results of Simplicity 3, which was the randomized controlled trials, and the results of this Simplicity 3 was very discouraging, because the renal denervation group was not superior on the control group, and the difference between both groups was not statistically significant. That's why renal denervation at that time stopped completely after this study. But they went deeply inside this study. They did a very deep analysis as regards the results of this study, and they found 3 confounding factors. The first one is that patients on Simplicity 3, they used to have drug changes and a great variability in their adherence to the medication. And this was the first confounding factor. That's why some trials put a specific protocol, what we call standardized stepped care antihypertensive treatment for all of patients undergoing renal denervation. The second confounding factor was the study population. Study population in Simplicity 3 were mainly elderly patients with isolated systolic hypertension. Isolated systolic hypertension in recent trials were a contraindication for renal denervation. They took patients with both systolic and diastolic hypertension. Patients with diastolic blood pressure less than 90 now is an exclusion criteria for the recent trials. So they excluded patients which were the main group of patients in Simplicity 3. The third one, there was the device used was using a single electrode, causing renal denervation of the main renal artery only. With the recent study, they used a multiple electrode catheter that denervate both the renal artery and the branches of the renal artery. And I would like to go back to this after few slides to show the difference between renal denervation of the main renal artery alone or denervation of the main renal artery and its branches as regards the level of norepinephrine in the blood and the level of post-systolic and diastolic blood pressure. I would like to start with the first confounding factors, which is the drug changes and variable patient adherence in Simplicity 3. In Simplicity 3, more than 40% of the trial subjects required medication changes between baseline and primary efficacy endpoint assessment. And this one of the drawback in this study, and this one of the failure of the results of the renal denervation in such patients. A second important point is that in addition to medication changes, they have a high rate of medication non-adherence in such trial. So let's go to some studies to overcome the problem of drug medications for hypertension, to have a studies in a drug-naive patients, those who were not receiving a drug for the treatment of hypertension, or those who were receiving a drug for the high blood pressure, but their systolic blood pressure should be less than 180 after stopping these medications. And some trials assess drug adherence, and some trials put a certain protocol for the medication. Let's go first for studies, including drug-naive patients. We have these four important studies. We have the spiral hypertension OFF study. This one was a pilot study in 2017. And now we have one bigger study, pivotal study spiral. In 2020, this study was published in Lancet in March 2020 and presented in the recent American College of Cardiology this year online. These patients were off medication, and they used the Simplicity spiral, which is a quadripolar device, catheter that causes ablation at different points, and at the same time they ablate the renal nerves at both the main artery as well as the branches. This is the same for the regions. The regions used an ultrasound for ablation of the main renal artery as well as the branches, and also these were hypertensive drug-naive patients. And we have a spiral, hypertension on, and TREO, all of these recent trials. I will go through this trial rapidly to show the results after adjustment of some of the confounding factors present in Simplicity 3 trial. And this is a spiral of medications. What was the difference between both group, the renal denervation group and the sham group? There was a significant difference as regard the reduction of both systolic and diastolic blood pressure in the renal denervation group as compared to sham group. And there was about 5 millimeter mercury reduction in the mean systolic blood pressure and 4.4 millimeter reduction in the mean diastolic blood pressure in the renal denervation group as compared to the sham control group. And this blood pressure reduction was evident both at the daytime and nighttime as measured and assessed by the ambulatory blood pressure measurements. And this is a second trial using an ultrasound for renal denervation. Again, renal denervation for both the main artery and the branches, which is the regions, solo using an ultrasound for renal denervation. And again, they found that a significant reduction in the mean systolic blood pressure in the renal denervation group as compared to the sham group, and the difference between both group was statistically significant. And the reduction in the blood pressure during the daytime and during the night as measured by ambulatory blood pressure was maintained in the renal denervation group as compared to the sham group. So we have these drug-naive patients. Actually, we have a good results with this renal denervation as long as we are using a multiple electrode ablation and ablating the main renal artery as well as the branches. And this is the result of the spiral on medication. Again, spiral on medication, they tested the blood change, the drug changes, and the adherence. In addition to the renal denervation group, again, the difference between both groups was statistically significant in favor of the renal denervation group in both systolic and diastolic blood pressure. These trials were made to overcome the confounding factors found in Simplicity 3 study. And again, follow-up of this patient over 6 months, they found progressive decline and progressive reduction in both systolic and diastolic blood pressure in the renal denervation group as compared to the sham control group. And this is a test for the drug adherence in spiral on medications, and they found that more than 60% of the patients were adherent to the treatment up to 6 months, and less than 40% were either incompletely adherent or non-adherent to their medication protocol. The second point, I would like to stress that a pre-specified drug titration protocol for this study for the nerve hypertension, they put a drug titration algorithm which called standardized stepped care antihypertensive treatment for all of the group, both in the sham control group and in the renal denervation, and they concluded that renal denervation was superior to the sham control group in the reduction in both systolic and diastolic blood pressure and the blood pressure as measured over the 24 hours. The second important confounding factor is the type of patients.
I'm starting in 3 minutes. For 15 minutes, 20 minutes, last question.
So I have to. Okay. What are the type of patients who were found in Simplicity 3? Most of them were elderly with isolated systolic hypertension. Their systolic blood pressure was more than 180 on 5 types of drugs, and the diastolic blood pressure was less than 90. Diastolic blood pressure less than 90 now is considered a contraindication for renal denervation in the recent trials. And they were asking about the reversibility of pathology in elderly patients. Actually, patients who have aortic stiffness and mechanical causes, definitely they have irreversible pathology that made this patient even resistant to renal denervation. And nowadays, isolated systolic hypertension is considered a contraindication for renal denervation. And if we look to this lady who has a porcelain aorta, do you think that renal denervation will make any difference in a such lady? Again, this is one of the contraindication in the recent trials. When they do subgroup analysis in the Simplicity 3 study, and they excluded isolated systolic hypertension, elderly patients, they found a significant reduction in both systolic and diastolic blood pressure in the renal denervation group in spite of using a single electrode and denervating the main renal artery, but they found a significant reduction in both systolic and diastolic blood pressure as compared to the sham control group. So with recent trials, we have to focus on early stage hypertension, and we have to focus on combined hypertension, and we have to exclude elderly patients with isolated systolic hypertension. The third point, what about the procedure effectiveness and variability? Because they were ablating only the main renal artery. And if we look to the renal sympathetic innervation of the renal arteries, we can find that nerve fibers don't completely converge on the renal artery until beyond the main bifurcation. And the presence of accessory arteries have similar anatomical innervation patterns that make the main renal arteries. And this is an important point to be taken into consideration. And this is a study measuring the norepinephrine level in the blood in the control group after denervation of the main renal artery after denervation of the branches, only the branches, and after denervation of the main renal artery as well as a branch. And they found that the significant reduction of norepinephrine in the blood occurred when we ablate both the renal arteries as well as the branches. And that's why this is a spiral branch, the mean versus main renal denervation only, they found again a significant difference as regard the daytime ambulatory blood pressure and systolic and diastolic, with a significant reduction in those who had ablation of the main renal artery as well as the branches as compared to those who had ablation of the main renal arteries again. Going back to this, from resistant hypertension, isolated systolic hypertension, elderly patients in Simplicity 3 in 2014 with a great failure and discouraging results, with a drug-naive patients and with younger patients with combined hypertension, definitely the results of renal denervation completely changed, which favors the use of renal denervation in such patients. And this is the last few slides as regard the most recent study for the renal denervation that published in the Lancet in 29th of March this year, and presented in the American College of Cardiology this year online presentation. And the conclusion of this study was very encouraging. This study included the pilot study of spiral off medication 2017 and pivotal study of this trial, about more than 300 patients treated with either renal denervation or sham control. The conclusion of this study, it was a powered trial, demonstrated that renal denervation lowered blood pressure in uncontrolled hypertensive patients in the absence of medications in both 24-hour and office blood pressure as compared to sham control. And they resulted in a clinically meaningful blood pressure reduction at 3 months. Treatment is very good as controlling the blood pressure for 24 hours, independent of patient adherence to medication, because these are drug-naive patients, and it was consistent blood pressure reduction during nighttime when cardiovascular risk is high. No major device or procedural related safety event through 3 months, and they are in the process of a spiral hypertension on medication trial. This is going trial and are enrolling the patients now. My take-home message is that scientific progress and interactive process after hypertension, Simplicity 3 has taught us to avoid antihypertensive drug confounding, that patient adherence, variability, and medication changes, all of this should be overcome. We have to focus on patients with combined hypertension, young patients with combined hypertension, not elderly patients with isolated hypertension. That's why in this recent trial, a diastolic blood pressure less than 90 is excluded from this study. We have to focus on early and even earlier hypertensive patients, and we have to treat both main and branch renal arteries. Thank you for your attention.
Thank you, Professor Nabil, for this wonderful presentation as usual. And I think based on the recent trial, you demonstrate it in an excellent manner. The guidelines may change about the renal denervation. I have two short questions and in short answer because of shortage of time.
Yes.
Is there a predictor for success of renal denervation? Predictor, the number one. Number two, who are the candidate for renal denervation, whether combined with medical treatment or the initial therapy instead of medical treatment? Who are the candidates?
This is very, 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 very important question, Dr. Tariq, because they are, I would like, there is still a dilemma as regard patient selection and who are going to benefit from the renal denervation. But at least after deep analysis of the Simplicity 3 study, elderly patients with isolated systolic hypertension should not be done. These patients should be excluded. And again, we have to concentrate on young patients who are having both systolic and diastolic hypertension. The trials done on drug-naive patients, this aim to do this to isolate the effect of medications on the trial, and to be sure that we are studying only the renal denervation as an important factor for the reduction of blood pressure, and they found this was successful. Actually, up till now, we don't have a selection criteria for which patient is going to benefit and which patient is not going to benefit, but at least if we are taking into consideration what I said as regard elderly patient with isolated systolic hypertension, patients who are taking a lot of medications and in spite of that, their blood pressure is still not controlled, taking 5 drugs, for example, and the blood pressure is still not controlled, I think all of these patients will not benefit from renal denervation.
في question from the audience about the hypertensive emergency and the urgency. هو بيقول what are the approach to hypertension emergency and urgency. I think is there rule for renal denervation in hypertensive emergency?
No, at all. Hypertensive urgency should be treated as we know, as written in the book. Urgency, we can give him medication or her medication, and the blood pressure can be controlled over the 24 hours by even oral medications in urgency. And in emergency cases, these patients will need to be admitted in the CCU, receiving intravenous medications to control their blood pressure, but renal denervation has no role in such patients.
Do you think that the definition of resistant hypertension will change? 3 drugs is enough to define resistant hypertension?
Yes. Still, the definition of resistant hypertension is the same. Patients who are receiving 3 drugs, one of them is diuretic, and their blood pressure is not controlled. This still the definition of resistant hypertension, but we have to exclude what we call pseudo-resistant hypertension, because some patients are taking 3 drugs, but the lifestyle is bad. Eat salty foods, obese, very obese patients, other risk factors, lipid profile is high, diabetes is not controlled, living a sedentary life. All of these factors should be taken into consideration before the diagnosis of a true resistant hypertension. Some patients are not adherent to the treatment. Some patients are not compliant to the 3 drugs, taking 1 of them or 2 of them, leaving 1. All of these factors should be excluded first before defining a true resistant hypertension. And the definition, as I said, is 3 drugs. 1 of them is direct.
Dr. Hani, you have any comment or you have any comment about the renal denervation?
It was a fantastic presentation.
Thank you.
I'm actually very keen on getting renal denervation to Egypt. I had done a few cases and I'm still following them. And I think especially the off-med trial was particularly important because it actually was a big proof of concept. Because after the Simplicity 3, there was some talk that the whole therapy might be a placebo.
I agree totally with Dr. Hani. I'm with the renal denervation. I think this is a good procedure, and we have to change our way of doing this, because we were doing this with a single electrode caster, ablating only the main renal artery. I think it's time to change, and I think the spiral caster, it's a quadripolar caster, and we can denervate both the main renal artery, and it is a small caster. We can use 6 French guiding caster, and we can ablate the branches with this caster as well as the main renal artery.
Is there a rule for cryoablation?
I didn't read anything about this, but I read about the ultrasound ablation.
Ultrasound guided.
Yes.
Thank you. Dr. Sobhi, if you comment.
Yes, okay. I have two questions to Dr. Nabil. Well,
Yes.
first, thank you very much for this wonderful lecture, as usual.
Thank you. Thank you.
Regarding the ultrasonic and renal denervation,
Yes.
last year they found that ultrasonic is better than.
Yes.
Yeah.
Yes. Yes.
So, your explanation for this. The second, already in the history of renal denervation, is claimed that it could be used in obstructive sleep apnea and heart failure in patients with paroxysmal atrial fibrillation. So, do you think
Yes.
that we're still going in any trials about this? Because if you believe in simplicity after 3, which your arguments could be effective in others, that then because already the problem was many study population and the technical code, main branches and the side branches.
Yes.
You said that in the last trial. So how do you explain all these puzzles?
Thank you, Dr. Sobhi, for this very important question. Number one, as regards the difference between using ultrasound and the radiofrequency ablation, and it was found that renal derivation transcaster, and if ultrasound used from outside, this is failure, but transcaster renal derivation using ultrasound even achieved better results than radiofrequency ablation. But actually, it is a comparison, a trial with a trial, not a head-to-head comparison in one trial. It's trial as compared to another trial. So they conclude this, that it can be better than radiofrequency ablation. As regard this technique for other diseases like heart failure, obstructive sleep apnea, COPD, and actually, I didn't read about ongoing trials for this. The ongoing trials are only for the renal denervation, and now they are enrolling the spiral hypertension on medication.
The claim of the renal denervation when before simplicity or after simplicity is another argument that we don't understand the pathology of the renal receptors. So they claim to have a local injection of a drug plus the renal denervations, or you make a neuromodulatory approach, or just local alcohol, or just aprezoline injections.
Chemicals injection, chemicals.
Do you think that still we need this combined technique for the denervation of the renal nerves, rather than just taking on a spiral form of changing the catheters, or it's okay, it goes after this, we can repeat again or revisit it and come back to what we started?
I don't think we need alcohol ablation in addition to the radiofrequency ablation, because the design of the catheter changed. The way we ablate the renal artery and branches become different. So we have an advancement in the technique itself, advancement in the catheter. With this advancement, we achieved better results, better reduction in systolic and diastolic blood pressure. And I don't think in the meantime, we have to add another thing with this radiofrequency ablation, not to complicate the procedure more and more.
Thank you. Thank you.
Thank you very much.
Thank you, Professor Nabil, for this presentation. And we now shift to the second topic. Thank you very much.
Good afternoon, everybody. Thank you for...
Okay. It's my pleasure to introduce my dear colleague, Professor Hani Raghi, to speak about nocturnal hypertension, which I consider a main practical issue for the diagnosis of hypertension. Welcome, Dr. Hani.
Thank you very much, Professor Zawawi, and thank you, Professor Sobhi, and the European Society of Hypertension. And I extend my greetings to our friends being across the Mediterranean with us now, even though they couldn't come in person, but I wish them safety. I will briefly discuss nocturnal hypertension. I'm just putting my timer, yes. I'd just like to say that I have no conflict of interest regarding this presentation. Of course, we all know what blood pressure is. It's the pressure of blood against the walls during the heart contraction, and you have the systolic and the diastolic. if you put a 24-hour blood pressure monitor, you'll see that when people wake up, their blood pressure surges. And if they rest, it goes down. If they exercise, if they garden, it goes up. When they sleep, it goes down and it dips. So at least a 10% difference between the nighttime and the daytime, and this is dipping. And then it goes up gradually towards breakfast, towards the morning. And if you have something like this, you worry. If the blood pressure doesn't go down at night on a 24-hour blood pressure monitor, it's something which would make you worry. There were two articles which I'm going to specifically focus on, and one of them was the one by Kazumi Kario in Hypertension in 2018 about nocturnal hypertension, new technology, and evidence. And the definition was restated. It was always blood pressure at night of more than 120/70. Actually, this has just recently changed to 110/65 on the new ACC-AHA guidelines. If you have a blood pressure at night of 125/80, and you have a normal blood pressure in the daytime as 130/80, this condition is called masked nocturnal hypertension. So here you go, possibly a new definition for some of us. And if the patient is already taking medicines and their morning blood pressure, the daytime blood pressure is very well controlled, but their nighttime blood pressure is 130/80, then this is called masked uncontrolled nocturnal hypertension under medicated condition. So there are many new definitions, and it usually used to be measured by ambulatory blood pressure measurement. But recently, there are several home blood pressure systems, very normal Omron machines like the 501, which you use for daytime blood pressure measurements, that you can just press a button and they'll measure, and just put the cuff on your arm, and they'll measure your blood pressure very comfortably during the night at 2 or 3 or 6 or whatever times you time them to. It's pre-timed. The number required may be more than 6, and the dipping is should be about 10%. If you're an extreme dipper, you dip more than 20%. If you're a non-dipper, you're less than 10%. If your blood pressure at night is higher than your blood pressure during the daytime, it's called a riser. Many conditions cause nocturnal hypertension. Older age, sedentary lifestyle, people who don't exercise, sleep and hot temperature, risk sleep meaning people who sleep very late and have a poor sleep, the summer, diabetes as a disease, chronic kidney condition, and obstructive sleep apnea are 3 diseases most frequently associated with nocturnal hypertension. These are some of the definitions I discussed, like the morning blood pressure, masked nocturnal hypertension, where you have normal blood pressure during the daytime, and nocturnal hypertension at night is just a table which we already. So research development in nighttime high blood pressure is, there are now nighttime machines which can have a lot of data from Japan, which can measure your blood pressure at night preset to different times. You don't need ambulatory blood pressure machine. It's the same machine you measure during the day. You just put it at night. You don't have to do that every night, but you might want to if you have nocturnal hypertension. These nighttime machines might actually be triggered by certain, so you can have it triggered by hypoxia with a thumb oximeter. You can have it triggered by heart rate. So again, because if you're testing a patient who particularly has obstructive sleep apnea, you want to know what happens to them during the hypoxic spells. And again, those machines have been developed and they're very interesting. And we have those, sorry, let me show you the previous slide. This is the TNP, which is trigger nighttime blood pressure, TNP. So double TNP is now being studied in the SPREAD study, which is sleep pressure and disordered breathing and resistant hypertension cardiovascular disease. Yeah, you can hear me? Can you hear me? Hello, can you hear me?
Yes, okay. Go ahead. Go ahead.
actually, those patients, recently, a 36-year-old man in which a triggered device detected exaggerated hypoxia, triggered nighttime blood pressure surge. And this patient developed the sleep onset of ischemic and hemorrhagic stroke, and a 74-year-old woman with obstructive sleep apnea, even when the mean nighttime measured was normotensive, the TNP determined that repetitive exaggerated hypoxia peaked her blood pressure to 160 millimeter for systolic blood pressure. So it's not just the nighttime, because the nighttime, the machine might measure during a good moment. But if you trigger the nighttime machine to measure on hypoxia, for instance, for CPAP patients, that's another story. And of course, these systems have been designed for night-by-night evaluations, and they actually send the patient's data to a cloud computing system from the blood pressure device in the patient's home. The patient, and now, for instance, with something like the COVID, the patient doesn't even need to come. They have the device, and it measures everything, and you as the doctor can see it. And you can see the daily obstructive sleep apnea severity, the sleep quality affecting the hypertension, the salt and alcohol intake. If people drink alcohol at night, it can lead to a night surge, which can be quite dangerous. Bedtime data, sleep time data, nocturia, people who get up at night multiple times, like a patient with prostate problems, who urinate, all this can affect your nocturnal hypertension. And most importantly is evaluation of CPAP therapy for patients with obstructive sleep apnea. The ITNP devices can evaluate the adherence and the efficacy of a CPAP on a day-to-day basis, and they do not disturb the patients. And when evaluating hypoxia, peak time night systolic blood pressure, you can see amazing reductions once you use the machine of more than 42 millimeters mercury using those devices. Just very quickly, you can have the nighttime dipping, which can be affected by salt and chronic kidney disease, heart failure, diabetes, and structural vascular disease, and simple insomnia. You can have the nighttime surges, which can be caused by obstructive sleep apnea and arousal, and rapid movement sleep, and nocturia. And these can be quite dangerous. And of course, you have the morning surge, which can be exaggerated in cold and exercise, and in smokers, and people who drink alcohol at dinner, and people who have sleep apnea. So this is what you look at, and those machines sometimes give you such curves, and this is what you're studying in nocturnal blood pressure. And you also, we have learned the mechanisms of nocturnal blood pressure, affecting how it affects how it untoward effects on humans. So it can cause increase in circulating volume because the patients are supine and they have high blood pressure, which can cause increased intraglomerular pressure, kidney injury. It can increase the preload in the ventricle, leading to heart failure in liable patients. Nocturnal hypertension leads to vascular damage, which can lead to a baroreflex activation, nighttime blood pressure surge, which can trigger a stroke, and not or a myocardial infarction early in the morning, and increased vascular dementia in such patients. So nocturnal hypertension is not by any way a benign condition. This is just an example from one of those advanced devices, which shows you in the middle curve, in the middle here, blood pressure is detected by the triggered nocturnal blood pressure machine. And in the bottom here, blood pressure measured by this machine in a 50-year-old normotensive woman with obstructive sleep apnea. It's successfully detected the highest peak of the night sleep, because if you had measured here, you would have missed it. But measuring here, you detected a systolic blood pressure of 184 millimeters mercury. When once you actually started treating her, her blood pressure went down to 127 at night. So those trigger devices, which are going to be available and are not expensive, and you can use them for patients at high risk, are useful. And not only that, we now know how to target and treat. This is a possible management strategy for nocturnal hypertension. So for instance, If you want to target a increased circulating volume, you have to find the cause of the nocturnal hypertension. If the patient has increased circulating volume, you will do salt restriction, diuretics, or you can use ARNI. If the patient has vascular disease, use calcium channel blocker. Obstructive sleep apnea and sympathetic activity is the cause, you will use the CPAP. Possible renal denervation, Dr. Nabil Farag. If the patient simply has insomnia, you have to make them sleep better by either sleep assistance or even meditation. So, and then you can test them, and you have to avoid the nighttime blood pressure surges. There's a study which I'll show in a minute, but I also want to show that we need our own studies in Egypt, because in the Jackson-Haas study, which was published on the 3rd of February 2020, the morning blood pressure surge in American Black adults did not actually result in a problem, whereas the high awake and asleep systolic blood pressure caused MACE. So in the Jackson-Haas study in Black adults, 761 patients, the average, the nocturnal hypertension was not found to be so harmful as compared to the high systolic blood pressure during the day. And so you need to have your own data on your own patients. There are several predictive models which are developed. For the sake of time, I don't want to go through them, but now we have the CARDIA study. Again, these are pretty modern papers which are published in 2020, which is studying the coronary artery risk development in young adults. And again, there is a model looking at sleep characteristics, people who go to sleep late, who don't sleep well at night, who drink alcohol at night, and nocturnal hypertension and non-dipping blood pressure in the cardiac in young adults. And it suggests that addressing obstructive sleep apnea and sleep timing is very, very important in a clinical trial, may improve blood pressure during sleep. This is the final presentation, which is again from Kazumi Kario, which is the J-HOP nocturnal blood pressure study, which was published in Hypertension in 2019. Is the nighttime blood pressure measured by home blood pressure monitoring, simple home blood pressure monitoring, using a standard commercially available machines, which are timed with timers as independent predictors of cardiovascular events in general practice. The J-HOP nocturnal blood pressure study is measured by home blood pressure measurements, and the conclusion of this study was that the home blood pressure, nocturnal blood pressure, was a strong predictor of future cardiovascular events independently of office blood pressure, morning blood pressure, or even evening home blood pressure, suggesting that this nighttime home blood pressure is worth monitoring, in addition to conventional home blood pressure, to reduce the cardiovascular risk. And we need randomized trials for that. This was the total cardiovascular events, and the higher quintile you got, the higher quintile nighttime systolic blood pressure, the worse were your total cardiovascular events, the worse were your stroke events, and even your coronary artery disease events. And these are the Kaplan-Meier curves for both the total cardiovascular events, stroke events, and coronary heart disease events. And you see that with the higher numbers, you get more events of nocturnal blood pressure independently of blood pressure. This is my slide before last. What is new? We have no studies to investigate the prognostic importance of night blood pressure using home monitors and not ambulatory monitors. And this study showed for the first time that you could do that. And in this large nationwide practice study, nighttime blood pressure using a new home monitoring device predicted cardiovascular events independent of other blood pressure measurements. This is my last slide. Nocturnal hypertension is an important determinant of MACE, of stroke, and of cardiovascular disease. Chronic kidney disease is evolving progress being made in automated assessment using home measurement devices on an impact of different medical conditions like aging, heart failure, obstructive sleep apnea, on the impact of different types of therapy and the timing of drug therapy. There has been a study showing that if you give something like candesartan at night or amlodipine at night, it actually can ameliorate nocturnal blood pressure. And it should be obtained in all hypertensive patients, especially those at higher risk of nocturnal hypertension, like the older patients, the CKD disease patients, and the obstructive sleep apnea patients, stroke patients, and obese patients. Thank you very much, and stay safe.
Good, Tarek. Thank you very much.
Thank you.
Yes, okay.
Thank you, thank you, Professor Hani, for this excellent presentation. I think, as you demonstrate, the nocturnal hypertension is not a benign condition, which resulted in the target organ damage in some cases. And you mentioned a term, masked nocturnal hypertension. Some studies mention that the nocturnal hypertension may precede the onset of office blood pressure. My question to you: how to practically how to diagnose nocturnal hypertension or suspect nocturnal hypertension if the patient has target organ damage with normal office blood pressure or normal home blood pressure? When you suspect that the patient has nocturnal hypertension.
Thank you very much, Professor Tariq. This is a brilliant question. Sometimes it's very difficult to suspect it, but you mentioned one of the criteria. But also there are certain patients whom you
hear me?
Yes, I hear you very well. Do you hear me?
Hello?
Yes, can you hear me? Can you hear me?
I hear you, Hani, and I hear you.
Yeah, can you hear me now?
Yes, okay,
okay,
go ahead.
I'm talking. So you suspect it in certain patients. For instance, in elderly patients, it's commoner than in young patients. In obese patients, it's common. In patients with suspected obstructive sleep apnea, it is common. In patients with chronic kidney disease, it is common. And trying to diagnose it is important because of two things. Number one, it's probably a treatable condition. Sometimes simply by moving the timing of the drug dose. We do know that in the HOPE trial, the majority of patients, the HOPE trial, as you know, which laid a lot of our understanding on the benefits of ramipril and ACE inhibition in high-risk patients and reduction of stroke, most of the patients were taking the dose not. So if you suspect nocturnal hypertension and you don't have the means to diagnose it, you might want to move one of your medications, not a diuretic, obviously, to the nighttime dose. And this might help. You might want to send the patient to a sleep study, and that they might diagnose the nocturnal hypertension for you while they're doing the sleep apnea if they measure the patient's blood pressure at night. We hope that the ambulatory blood pressure machines, which actually do the nocturnal measurements at home, would soon be available because these are not expensive. Patients like to have a home blood pressure machine, and they do measure their blood pressure at night. And the new ones in Japan actually are connected to the cloud, so they actually send the patient's data automatically to you. I think, I hope I'm right, I think that during our lifetime, we're going to see that measuring blood pressure at night with home devices, not having to go to hospital and wear an ambulatory device, with simple home devices is going to become common practice. We need to know. And the whole point about this, Professor Zawawi, is that the heart workload at night, when the heart should be resting, the heart is resting from the stress of every day. In patients with nocturnal hypertension, it's almost like they're running 24 hours a day. The hearts get exhausted, and we have problems, and a lot of patients may go into heart failure. Thank you.
Hani, the questions coming from the audience regarding, can you explain again your curve about the riser, the dipping, how to measure the dipping, and about 40%, 20%, 10%?
Yes, yes, of course.
This is an important point for them. And the second question regarding this is the day hypotension. If you suspect and you give drugs to these patients, there are 2-3 questions like this. You change the drugs to at night. So are you afraid to have hypotension in the morning? So this is the second.
Yes, this is an important. They're all important questions. Thank you very much. Do you see my slide? I went back to the slide.
Yes.
Okay. So
have a slide.
Yes. Here you go. So the last lines in the slide, blood pressure dipping patterns are defined. An extreme dipper is somebody who dips more than 20%. Yes. A dipper dips between less than 20% but more than 10%. A non-dipper dips less than 10%. to 0%. And a riser has a higher blood pressure at night. This classification is usually based on ambulatory blood pressure measurement data. We're not terribly sure about the home blood pressure measurement data because they actually show us surges, which can be different. Giving the nocturnal, giving a dose at night, it is important that the patients do not go into extreme hypotension, especially with the elderly. So that is usually unlikely, okay? Especially if you don't give a combination drug at night and you don't give a diuretic at night. If something like amlodipine or an ACE inhibitor is given at night, that has been shown in several. There's been a study which I haven't shared here, which showed that candesartan at night. Let me show you. I think I have it here. The patient was given candesartan at night, and this fixed their the peak of their surge.
Because of
here. Let me show you this slide. This patient had a WSP trigger, which detected the highest peak of blood pressure at night on the day before, and then they gave them carvedilol on a nighttime dosing, 20 milligrams, and it decreased the surge index from significantly, and the peak of the surge was decreased from 178 to 133 millimeter by the oscillometric method, which was triggered by hypoxia. So you can give drugs at night. For instance, a drug like carvedilol, which already easily has twice daily dosage, you can give, instead of giving the whole dose in the morning, you can give half the dose at night. Again, you can give some ARBs and ACE inhibitors at night, but you do have to avoid nocturnal hypotension.
Okay, thank you very much, Tariq.
You're welcome.
Thank you. Yeah, thank you, Professor Hani, for this wonderful lecture. Dr. Tariq.
Thank you.
Thank you very much. The last speaker.
Thanks regarding the special topic session. Thanks, Professor Hani, Professor Nabil, and Dr. Tariq. But unfortunately, Dr. Sharif Zawi has a technical problem, so we record his presentation and we will introduce it to you again next time. But now we come to the final closing remarks of these two waves. I have with me Professor Tariq Zawawi, the man behind all these successful program in 4 days, 2 waves, and we have our two international speakers, Dr. Enrico, past president of the European Society of Hypertension, and Dr. Costa, the immediate past president. Before I have my closing remarks, Dr. Costa has a few slides to introduce to all of you regarding the European Society of Hypertension. Dr. Costa.
Thank you, Mohammed. Dear friends, dear colleagues, it's a great pleasure for me to say a few words during the closing of this very, very nice and very successful meeting. And actually, this meeting has some key characteristics. It is the first ESH virtual meeting thanks to the COVID-19 pandemic, and it really works perfectly. I would like to congratulate the organizers, the ICOM, for this great job that they have done. It was a great experience for all of us as moderators, as speakers, but I am sure also as an audience. And many thanks to Professor Mohammed Somgi and to ICOM for this excellent organization. The program was of high quality, covering many topics. I think also from the diagnostic aspects to the therapeutic management, included specific topics according to the gender, according to the age, according to the comorbidities. And one very, very good characteristics of this meeting is the interaction. Very well placed questions, very good discussion. And this is really great because this is the purpose of the meeting, not only to deliver talks, but to discuss with the participants and to share our experience. This meeting is actually in line with the main purpose of European Society of Hypertension. When ESH was established in 30 years ago, based on the dreams of Professor Alberto Zacchetti, was to reduce the hypertension-associated morbidity and mortality in Europe and beyond Europe. through collaborations, through research, through education. And education activities are the backbone of our job. ESH organized meetings with physical presence in the past, now virtually, as it was this event. We produce guidelines, we have our own journals, organize webinars. Summer school is a very, very successful initiative, and I am sure that at least every year we have 1-2 participants for Egypt, and we will be more than happy in the next years to continue to have physicians from your country. European hypertension guidelines is very, very well appreciated all over the world, and we have the opportunity during this 4 days event this week and the previous week to discuss many aspects of the guidelines. And of course, we have our own journal, European Journal of Hypertension, very successful journal, and the Manual of Hypertension. We were happy with Giuseppe Mancia, Guido Grassi, Anna Dominsan, and with Agape Di Rosei to present a few months ago the new edition of the Manual of Hypertension. Last but not least, ESH supports research projects, and now we are running the blood pressure control in the ESH Excellence Center. Because ESH works, we work all together. We are based in a huge number of ESH Excellence Centers, close to 200 Excellence Centers dedicated to research and also to training the next generation of hypertension specialists. And national hypertension societies, European national hypertension societies, but also affiliated and associated hypertension societies beyond Europe represent the backbone of society. And I am sure we already have a good relationship and cooperation with Egypt Society of Hypertension. And I am sure in the next years we can improve further our cooperation. With all these small few words, I would like again to congratulate the organizers for this great meeting, and we are looking forward for the next series of such meetings, either with physical presence or through the web, as it was very, very successful experience. Stay safe, stay healthy, and I'm looking forward to meet you personally in the near future. Thank you so much.
Thank you, Costa, for all of this. We'll start, my thank you for all what you did for us together in. Okay, okay. Thank you very much, Enrico. Thank you very much, Costi and to Professor Tariq. Actually, personally, the first experience for me to have virtual meetings, this long virtual meeting, and translate a conference to this virtual meeting. The idea came during the COVID era. Actually, was planning to have this meeting in March, but we postponed because of the beginning of COVID. So and getting together. So we decided to postpone, but we don't know what's the exact date. So the idea came me and Dr. Tariq and ICOM to make it in waves. Not the long days, but waves. So wave 1 and wave 2 started wave 1, 10 and 11 of April, and wave 2, 17 and 18 of April. So we need to thank you all for your virtual presence, and this event has succeeded, I think, with your participations. We have a very successful waves, which, as you can see, the program starts for here. This is 2.5 hours on Friday, and then 3 hours in Saturday, 11 of April. In Friday 17, we have 3 hours, and Saturday we have 2 hours and 15 minutes. We have 8 unique sessions in our virtual events. And when I look to the sessions, I think it's, if you make it 2 days, long days, sometimes you cannot realize what's important is. But when we divide it into virtual, into 4 waves, I have the time to look after hypertension, diagnosis and risk, hypertension with heart failure, management of hypertension. We first debate beta blockers, maybe the first or not, hypertension comorbidities, diabetic nephropathy. Second debates the hypertension special population and special topics. So we discussed 10 great topics in wave 1 and 12 great topics in grade 2. And we have 2 symposium in wave 1. Thanks to Novartis Symposium, the Novartis company, who was the main shareholders, the new smart proof in hypertension was this lecture was by Professor Adel Atribi, and Abbott Symposium by myself. How do dihydropyridine and non-dihydrating calcium blockers differ? Thanks to Abbott to be a second sponsor. The first symposium in wave 2 was by Novartis, by essential intervention by Professor Muhammad Sadat. We had the pleasure to have eminent experts in our programs. Actually, we have 2 international experts and 21 national experts. Thanks to our prestigious international experts, this is not the first time. Enrico have with us 3 years before, and this is the 4th year, and Costa as well. Enrico Rossi, past president, European Society of Hypertension, and Professor Costa Tisiofi, immediate past president, European Society of. Thanks all of you. Thanks. I enjoyed your lectures. I enjoyed your interactions with all of us. Thank you very much for your efforts. And also thanks to our prestigious national experts. We have Professor Adel Atribi, Professor Ahmed Bendari, Professor Ahmed Amrawi, Ahmed Shawqi, Amin Fuad, Amr Zaki, Said Farag, Hana Azawawi, Hani Ragi, Hisham Abu Lanin, and Hisham Salah al-Din, Mahmoud Hassanin, Muhammad Lotfi, Muhammad Sadqa, Muhammad Subhi, Nabil Farag, Usama Sanad, Sharif Zawawi, Sharif Wagdi, Tariq Zawawi, and Yasser Hussain. And myself, and special thanks to Professor Tarzan, who did the program, and we spent a lot of time together doing this program before March, and then how to divide this into 2 waves and 4 days was so difficult, and I think we succeeded to make it easier for all of us. Thanks, special thanks to Professor Tariq Zawi. And I give you this is usually have in all our conference was known at a D record. So I think I asked Riham, Aikum, and Ahmed Yusri and Hazim to record that in D records, and was surprised. The first day was 507 viewers from 13 countries, from Egypt 289. From Saudi Arabia, 17, Lebanon and Jordan, Emirates, Kuwait, and Yemen, and also from outside, from USA 8, Korea 2, UK 1, Malaysia 1, Ireland 3, and Hong Kong. So in practice, sometimes it's difficult to bring all of these into physical conference. On the second day, we have 4 viewers from 19 countries, the same Arab countries, together with Palestine, Libya, and Kuwait. And again, we have more countries from outside Germany, Italy, UK, Netherlands, Norway, Austria, Malaysia, Hong Kong, and Ireland. This is for the first wave. The second wave, in 17th of April, we have 367 viewers from 16 countries. The same country, but added to them Jordan and Iraq. And from outside the Middle East, we have still we have USA, adding to Canada, Bangladesh, France, and Bulgaria, apart from Ireland, Malaysia, USA, and Germany. So the 4th wave, the 4th day, today, I stay till the end. I just have this presentation a few minutes before I give it to you, because I have to have the main viewers up to the end, 320 viewers from 14 countries. Again, we have the same countries, but adding to this Bahrain, added to, and Emirates increase. USA 4, Mexico 2, Turkey, which is this new for the waves. Netherlands also 2 doctors, and the same UK, France, and Malaysia. As you can see from all the Arab countries and all outside, so it's not less than 300. As you can see, the first day was 507, second day 400. This first wave, the second wave 367 and 320. My special thanks to our main sponsor Novartis for all these drugs, and actually this Novartis well-known company for CME. The second company, thanks to our co-sponsor Abbott and Merkel Cardiac Alliance for doing this for us to help in these virtual meetings. And my special thanks to ICOM and Media Factory teams, especially in ICOM, Walid Menesi, Riham, responsible for the program, Salma, Ahmed Shal, and Bilal Shal, and or for the Media Factory, Ahmed Yosri and Hazim and all his group. For this Media Factory is completely different from other virtual meetings. I noted that they make it like studio. They can speak to us, directing us without taking just a Zoom. I know that we are doing a lot of virtual, but this is technical. I learned personally. I learned from them. I learned how to do the virtual now. Looking for the questions. The questions was done by a special parts. It's not only by chatting, not by the questions, but also by WhatsApp and also by a special site link to me. And so this was wonderful for the media company and wonderful also for the program to divide. And I can thank you very, very much. Now we are going with Dr. Tariq, Dr. Enrico, and Dr. Costa for their opinion and recommendation for the next year, my colleague. Thank you very much. Dr. Enrico, what's your opinion and recommendation for the next year?
Thank you very much, Mohammed. Well, first of all, I'd like to meeting, and you, Mohammed, had already reminded that we planned to have the meeting on March 12-13, and this became impossible because of the spread of the epidemics. And at the end, there was this decision because it has been felt that it is very difficult to plan another meeting during this year. And I have to say that this decision was very well taken. And we have had this meeting by remote that has been a great success on my mind. It has been very well organized. It was so clear. It was immediate with presentation that have been on very interesting topics, very updated, and we had also this nice discussion. So possibly next year we may have a live meeting. We are happy of that because we need also live meeting. We need to physically see each other. But anyway, this meeting, this format can be also replicated because it has been really a great success. I have just to remind you that the meeting of the European Society of Hypertension joined with the International Society of Hypertension will be held in April next year from 11 to 14. So in the choice of date, take into account this meeting. It would be nice to report what are the last achievement of research in hypertension. I think this year many topics have been discussed which are extremely important in clinical management of our patients. Of course, I don't know, but for next year we have to discuss what is the main problem now for hypertension. Why, despite so many good, fit, effective, well-tolerated drugs, why after so many research, the control of blood pressure in the population is still so low. And we can talk about adherence, medical inertia, and all the factors that may affect this control of blood pressure. Perhaps also we may discuss about new antihypertensive drugs. It's not easy to find new drugs that may compete with existing ones. But we may also look at drugs coming from other areas, such as diabetes. We know how SGLT2 inhibitors may also reduce blood pressure and may be useful for preventing complication of hypertension. Another example is, of course, angiotensin receptor neprilysin inhibitors. We may discuss about this. In addition, we should also look at new important risk factors, including psychosocial risk factors, including pollution, airborne pollution, and also stress. This will be more and more important. And of course, we will have time to discuss about COVID-19, how much it has interfered with our activity, with the health of patients with hypertension, diabetes, and so on. And then we have other more classical topics in that we may discuss in terms of update, what is new, with debate, and anytime with the presentation, I think it could be interesting to have take-home messages to keep in mind. But as I said, this meeting has been very successful. I think it has been very well accepted. I congratulate with you all. I don't want to repeat all the congratulations to single person that have worked so much in this meeting, but I congratulate any of you, and I hope to continue to work with you. Thank you very much indeed.
Costa, do you have any idea for the next year?
I think that Enrico covered in an excellent way all the topics. I fully agree with him. I think just a few words to say that since hypertension is associated with many comorbidities, I think that diabetes mellitus is something that we could discuss in a more extent next year. Also, interventional therapies. I was happy to see that renal denervation was included, but in light of the new trials, I am sure that at least next year we will have some more data in this area. And as Enrico mentioned, I think antihypertensive management in the era of COVID-19 or post-COVID-19 era, I think is very interesting. It is nice to see in this difficult and unexpected condition of COVID-19 that hypertension also is on the center. That means that our topics is of high importance for the management and of many conditions, even for infection conditions, hypertension is involved. Thank you so much, and I think next year we can combine the physical presence and also with live streaming to the other countries, since this experience this year was very, very successful. Thank you so much for your efforts. Congratulations for this great event.
Before I ask Ettore, I have a question to both of you. We're speaking about the COVID and the high-risk populations who are high mortality. We noticed that in many webinars, we don't know why hypertension of the high mortality rather than respiratory. It's cardiovascular first, and then hypertension, and then diabetes, and then respiratory, and CKD, and then. So why hypertension? They asked me several questions before, but I don't have the answer. What's explanation? Why the hypertensive patients are more risky to have mortality from COVID?
No, this seems not to be correct. We have the position, the statement of ESH. Recently, our president, Professor Klaus, published a very nice update of this statement in the European Pharmacology Journal, where it seems that this association of hypertension with severity of COVID-19 is confounded mostly by age. This is the first point. And the second point, the fact that SARS-CoV-2 uses the angiotensin converted enzyme 2 as a receptor for the entry in the lung cells and also in the myocardial cells, stimulate a discussion whether RAS blockers could contribute to the unfavorable outcome based on the animal studies. And very few data from human studies, it seems that RAS blockers, either RBS or ACE inhibitors, do not upregulate so much the ACE2. And if in case they upregulate, this upregulation does not translate it to unfavorable outcome of COVID-19. Of course, this is the position based on the current available data, and also there are animal studies suggesting that pre-treatment with RBS could be protective in the course of coronavirus. Up to now, no reason to change the antihypertensive therapy. Think hypertension first, follow the guidelines. This is the message.
Enrico, do you have any?
Yes, I also agree with what Kostas has just said, and certainly the prevalence of hypertension is so diffuse in the population, particularly in the elderly, that of course it's easy to find an association between the infection and the presence of hypertension. So age is a big confounder about that. Certainly hypertension may have also already induced some cardiovascular damage, although preclinical, and this may facilitate the severity of the infection and therefore also its consequences. As far as the issue of RAS blockers in patients with COVID infection, so far we have data suggesting that we cannot withdraw the treatment because of the fear of some suggestion. And I know that in a short time there will be an important study demonstrating that in fact there is no clear relation between the use of these drugs and the severity of the infection. So again, the recommendation is not to change your antihypertensive treatment just because of some supposed risk of these drugs.
Thank you. Tore, what's your, thank you very much again for what all your effort. What do you think, Tore, for the next year?
At first, I would like to mention that this is the first virtual meeting for CVREP in cooperation with the European Society of Hypertension. And one of the great advances that it is prepared just only 1 month apart from the scheduled lifetime. As Professor Sobhi mentioned, the time was in early March, and now we in the April. Just in 1 month, we can prepare this successful virtual meeting. And I would like to thank very much you, Professor Enrico and Professor Costa for their participation in this virtual meeting. And your participation was of great interest for the success of this meeting. Also, I would like to thank all the speakers and the panelists. I would like to thank even the audience and the chair doctors all over the world. And I would like to thank ICOM, because ICOM was a clever and technical techniques for the organization of this virtual meeting. Concerning the next year, I hope that these hard circumstances will pass rapidly, and the next year we'll go for live meeting and face-to-face meeting. And I hope for the hypertension per se, for prevention. I hope we need more prevention methods. We need more awareness, for public awareness. We make a lot of educational sessions for the doctors, and we ignore the public. We need more public awareness of the hypertension and the hazards of hypertension, because we know that the hypertension is a silent disease, and most of the public are not aware of the hazards of the hypertension. Also, we hope, as Professor Enrico said, new drug methods for the treatment. This is my hope for the future. Thank you.
And I agree with Enrico, Costa, and you, but I need more cases. We are defective in cases, so we need case interactions. I mean, makes it a real case. You can make one or two cases, and then one lecture.
This needs face-to-face meeting.
Yes, I know this. I like the physical. Usually, I'm social man, you know. So I like the physical. I like to meet. I like to take dinner with you. I take lunch to speak with you individually. I know that you can work at home, but this is not. We can make this virtual, repeated, but in a we cannot think now. But
educational manner.
Yeah, educational manner. We cannot wait till 1 year to have a big conference, and in between you can have some workshops, some ideas, some consensus. And lastly, we need to have a registry between European Society of Hypertension and CVRAP. We can work together to have more paperwork, main research. We can need some papers to be presented in these meetings from all over the world, not only from Egypt. This could be added the value for this meeting. So paperwork, presentation, posters, cases, and registry. This can be added to this wonderful. Thank you very much. And I need you after closing to have a group photo. Just smile. You know, we usually have a group photo for the last 4 years, but this is the first time to have a group photo with a smile without physical
from the screen.
No, just smile the screen and you'll have it.
Good.
Good. Just okay. 1, 2, 2.5, 3. Okay. Thank you very much, all of you. And okay. Okay. Thanks for the attendee. You can make the survey, please, and then go for the certificate within half an hour. You will have a certificate just to fill in the survey evaluation. And thank you very much again, and have a nice weekend. Bye bye.
Thank you.
Bye bye.
Bye bye.